Good afternoon, everyone, and thank you for joining us for our weekly Gecko session. Gecko is a project from the University of New Mexico, hosted locally by the Gastro Foundation, and we've got these sessions every Wednesday. Glad to see so many people on the call. We will keep the chat open for questions, and or you can raise your hand afterwards, and we can have a discussion. Today, I have the privilege of introducing one of our new fellows to you. Nouraine is recently graduated as a pediatrician, and she started off her subspecialty training in pediatric gastroenterology with us at the beginning of the year. She's going to present one of our cases this afternoon, and if I can ask you to start sharing, Nouraine. There we go. Good. I can see your slides nicely. So when you're ready, you can take it away. Thank you.
Nouraine, just check that you're not muted, please.
Oh my goodness. Can you hear me now?
Yes, we can. All good.
Sorry. Thanks, guys. Okay, so I'm Nouraine. As Tim said, I'm the Pediatric GIT Fellow currently rotating through VITS. And today I have the big task of presenting pediatric intestinal pseudo-obstruction, which is quite a large topic. And I think even before I started this presentation, I underestimated how important it was. And I realize it's important because it can be so easily missed or misdiagnosed if you don't have a proper approach. So my goal here today is to offer you some guidance in that regard. So, sorry, let me just move my slides, which is not happening. No, sorry. Disaster.
Okay, just stop the share and come back in with the share.
Can't get my mouse back into my screen.
Okay. I'm going to stop the share from my side.
Thanks.
Okay. Okay. Can you try and share again?
Wait a second. Sorry.
Okay, it always works perfectly when you're practicing.
Yeah, we just did this. So sorry, guys. I can't get it. Hold on, I'm going to quickly call for tech support.
Okay. Tim, would you like me to put up the advert just to while we wait for her to come back?
I think she's there, Cheryl.
All right.
I just think she won't be able to share if we're already sharing the advert.
No.
What's that?
Okay, I'm going to try sharing again.
Something's happening. There you
Okay,
go.
can you see it now?
Yes, we
Yep.
can.
Can you move it?
And if I change my slides, does it make sense now?
Yes, it's
There we
working.
go. Okay.
Okay, thank you. Sorry, I had to like get my husband to help me. Okay, sorry, everybody. Right, so pediatric intestinal pseudo-obstruction. So let me actually just start with the main stuff, lest we have another technical issue. So this is the thing that I want you to remember from this talk. So the first is that pediatric intestinal pseudo-obstruction is not the same as chronic intestinal pseudo-obstruction. So the peds and the adults are very different. Presentation and pathology are very separate between the two groups. So you can't really use the terms interchangeably like we've done in the past. It can present like bowel obstruction. So even though this talk is about pediatric intestinal pseudo-obstruction, it's not actually that common. So always remember to exclude mechanical causes first. In your diagnostic workup, abdominal X-ray is going to form part of it, and we'll go into it a bit more later. But you'll see that abdominal X-ray is less helpful in our neonatal population. So be careful that a normal abdominal X-ray doesn't exclude the diagnosis of PIPO in this group. Always think about the bladder. So at least a third of your patients are going to have urological involvement. So always inquire about it both at the time of diagnosis and subsequent follow-ups. And as pediatrician, we always think about nutrition, but it's very important to think about nutrition again at the diagnosis and at follow-ups, because 60 to 80% of your patients may ultimately require TPN, and whether that's feasible or not, we'll see. But to keep in mind that nutrition is something to monitor actively. Okay, so to anchor these concepts, let's start with a case. So at Rahima, we saw a patient IM. He's a 6-year-old male. He presented with abdominal distension and soiling. He was known to be a picky eater with early satiety, and his mom reported that he vomited quite regularly after eating, and sometimes it was noted to be bilious. In terms of past medical history, he had recurrent UTIs, refractory constipation, occasional episodes of diarrhea, and he's had no previous surgery. When we examined him, we found evidence of pedal edema. He was pale, he looked fatigued, he had marked abdominal distension, his abdomen was tympanic, but we found no ascites, and he had no intra-abdominal masses or stools that we were able to palpate. The rest of his examination was largely unremarkable, specifically the neurological examination. He had a normal spine, normal reflexes, and all of this occurred on the background of a very severely stunted and malnourished individual. So for our bloods, we didn't really find anything that was remarkable, except for an albumin that was 28 and a B12 of 80, which was also low. So both of these things suggested to us that there might have been some sort of chronic malabsorption picture happening in this patient. So we did an abdominal X-ray, and we found paucity of bowel, distal bowel gas pattern. There was no visible air in the rectum, and we can see what looks like dilated loops of bowel, which we thought to be large bowel, and we can't appreciate any air fluid levels in this film, but it's a supine film, so just remember it's not the best position to visualize that. All right, so what do we have so far? So we have a constipated 6-year-old who has intermittent diarrhea. He's got vomiting, sometimes bilious. He's not growing, he's quite malnourished, and on examination, he's edematous with abdominal distension. In terms of blood results, we have largely normal bloods, but he has a low albumin, low B12, and our abdominal X-ray shows large bowel dilatation. So what are we thinking at this point? For me, this looked like a picture of bowel obstruction, and we have associated malnutrition, but where to from here? So one way to approach bowel obstruction is to break it down into mechanical and non-mechanical. So I'm going to start with mechanical causes first, because we know that's not where the focus of this talk is heading. And the differential of mechanical causes are obviously much more than what I've given here, but these are the main things that I've thought about in this case. So I thought about volvulus and malrotation, and especially because this child is malnourished, it would be remiss not to think about TB or even malignancy causing like external compression. And in terms of non-mechanical causes, again, there are potentially a lot more differentials. But we always think about Hirschsprung's. He is 6 years old, so it is a bit late, but it has been known to present late, especially with our rate of pickup sometimes, especially short segment Hirschsprung's. With the background of malnutrition, stunting, we think about celiac and inflammatory bowel disease, especially because he has that intermittent diarrhea. And with the combination of the constipation and the clinical features of abdominal distension, we would be concerned about an underlying motility disorder. And that is where this talk is focused today. So let's get into it. This is kind of the order of events, pretty straightforward. So we'll talk about what it is, how common it is, how we end up diagnosing PIPO, how most patients tend to present, how we investigate them, and ultimately what we do to manage these patients and what our options are in our setting. Okay, so definition. As most things are, intestinal pseudo-obstruction was first described in adults in like 1958, and it took another 20 years before a paper was published in a pediatric cohort. And initially, adults and children with intestinal pseudo-obstruction were described under the same term of CIPO, chronic intestinal pseudo-obstruction. But like I alluded to earlier, children are not just small adults. So eventually, children got their own term, which has been defined by ESPGHAN as a disorder characterized by the chronic inability of the gastrointestinal tract to propel its contents. It mimics mechanical obstruction, but there is an absence of any lesion occluding the gut. And the chronicity is different depending on if your patient is a neonate or not. So in the neonatal period, chronicity is defined as 2 months, whereas outside of the neonatal period, at least 6 months of history. So this table highlights the differences between the peds and the adults. And there's actually a lot more to it than this, but these are the ones that I found quite interesting. So in terms of etiology, as we can expect in our pediatric group, the majority of cases are congenital or primary. Up to 80% of cases are actually congenital, whereas in the adults, it's about a 50-50 of a secondary or primary cause. In terms of symptom onset, most of your pediatric patients will have actually presented by 12 months of age, which is why it's important to have this as a differential, because you're going to see very soon that your presentation is not very specific, whereas adults tend to present in like the 2nd to 4th decade. In terms of presentation, in the adult group, pain is one of the features that you tend to see quite often and tend to be one of your main presenting symptoms, whereas it's not as common in your pediatric group. And important things to look for, again, in a third of your patients is that urological involvement and malrotation, which we don't see in the adults. In terms of outcomes, our pediatric group tends to have worse outcomes than the adults, especially in myopathic forms. The risk of mortality is approximately 20%, and a lot of our kids end up requiring nutritional optimization in terms of TPN or nasogastric or jejunal tubes. Whereas in the adult population, if you can restore good enteral feeding and your patient tends to present earlier, then you can have potentially good outcomes, which underlies the importance of nutrition. So how common is PIPO? So the short answer is we actually don't know, because we have poor standardization of definitions between case studies, which makes it really difficult to estimate the prevalence and incidence rates around the world. There's minimal registries, both nationally and internationally. So again, that also makes it difficult to find out how many cases there are. And because of the variable pathology, case definitions between studies also tend to not be consistent. But overall, what we do know is it's quite rare. We have numbers from a few countries, and the numbers from the US show a much higher incidence, as well as morbidity and mortality compared to what's described across the world in Japan. But again, because of that lack of standardization, it's hard to take this finding a step further to assess for associations with genetics or ethnicity or even sex. ESPGHAN reports the incidence of PIPO to be less than 1 in 100,000, with a varied mortality between 4.8 and 32%. And interestingly, most of the deaths are noted to be secondary to iatrogenic complications, such as post-surgical or sepsis. Okay, so let's talk etiology. So like I said earlier, in our pediatric group, the majority of cases are congenital or primary, and only 10% are due to secondary causes. Similarly to adults, however, the majority of our primary cases are secondary to neuropathic causes. So this is from the ESPGHAN guidelines, which is obviously based on well-resourced countries. So this specific slide is not a reflection of our African population. But globally, what they found is neuropathy predominates in terms of the underlying primary cause. Okay, so the next few slides are a bit content heavy, but I'm going to try and go through them a bit slowly. So I want to break down the various etiology that form part of PIPO. And like I said, that list is quite extensive, but we'll go through it one by one. So the first breakdown would be that PIPO can either be secondary to a primary cause, a secondary cause, or an idiopathic cause. Under primary, you can get sporadic or familial forms. You can get causes that are secondary to mitochondrial disease, or you can get neuropathy that's associated with MYN type 3. Secondary causes are a lot more extensive, even though they only make up 10%. And I've divided them into 5 main subtypes. So you either get secondary causes that are secondary to muscle pathology, neurological pathology, metabolic, endocrine, or other. So under muscle pathology, I've further subdivided into rheumatological and not. So rheumatological causes would be things like dermatomyositis, polymyositis, scleroderma, SLE, and others would be things like Duchenne's, amyloidosis, etc. Under neurological, you have things that affect the enteric nervous system, or you have neuropathy that's post-NEC. So things that can affect your enteric nervous system is actually quite a lot. So you can get familial things or primary things like familial dysautonomia, primary dysfunction of the autonomic nervous system, or you can get things like neurofibromatosis, secondary post-viral related inflammatory neuropathy. Even fetal alcohol syndrome can affect your enteric nervous system. So it's also a very broad subtype. Under metabolic, endocrine, I think these ones are a little bit more self-explanatory. And then other also encompasses quite a varying degree of underlying pathology. In Africa, we see a distinctive type of myopathy. So it's quite unique to the phenotypes found in the rest of the world. And it typically affects children of African descent in the Southeast and Central Africa. But other ethnic groups have also been described. So our subtype is called African degenerative leiomyopathy, and the underlying etiology is largely unknown, but about 60% of cases have been associated with the actin smooth muscle gene. However, this genetic variation is thought to occur de novo. I think there's only 2 cases which have occurred in the same family, which makes it quite hard to pick up and subsequently screen for. And it tends to cause this progressive degeneration of smooth muscle in the intestinal wall, and has been found to mainly affect the colon, extending to the anorectal junction. So on histology, you can see smooth muscle degeneration, vacuolated cytoplasm, extracellular edema, and you have this increased fibrosis in both layers of the muscularis propria. And in some individuals, it can even give this almost tigroid pattern, which I think I have a bit later on. So in terms of presentation, you have this like progressive abdominal distension, poor intestinal motility, which can look a lot like Hirschsprung's, but it presents much later. The mean presenting age is about 9.5 years. And obviously your biopsy will have the absence of agangliosis. So this particular X-ray was from a case study that was done in Bloemfontein in 2006. It was a 9-year-old girl who had confirmed African degenerative leiomyopathy. And you can see those significantly dilated loops of large bowel. And her diagnosis ended up being made on the clinical picture, exclusion of mechanical causes with a normal full thickness rectal biopsy. Unfortunately, genetics aren't always widely available and again may not be positive in 40% of patients. Unfortunately, this is a progressive disease, eventually involving the whole colon, so prognosis is quite guarded. Okay, so now you have a patient. Let's go back to our main thing. But so now you have a patient and you suspect PIPO. How do you ultimately make your diagnosis? So the diagnosis of PIPO requires 2 or more of the following 4 criteria. And I'm just going to take a second to go through them individually, because on paper, the diagnosis of PIPO appears quite straightforward. You just have to check 2 out of 4 boxes, but practically it can be quite challenging, especially in a lot of our settings. So the first is that you need an objective measure of small intestinal neuromuscular involvement, either manometry, histopathology, or transit. And by transit, we mean small intestinal scintigraphy, which is nuclear medicine scan. And already we can identify an issue of access with these particular tests, especially in public. So either due to not having skilled professionals able to perform this, the actual equipment, or in terms of histopathology, long waiting times. So contrast studies like barium enemas or swallows are not even mentioned here in your diagnostic criteria because of the lack of sensitivity and specificity. But I'll talk a little bit about what we do sometimes use and the pros and cons. The next criteria that you need to meet is recurrent and or persistently dilated loops of small bowel of intestine with air fluid levels on X-ray. And at least X-ray is something that's quite accessible, not without risk of radiation exposure, of course. And while they are used in older children with variable success, again, our neonatal population, 40% of them can have a normal X-ray. And identifying specifically small intestine on your X-ray film can also be a challenge. The next criteria would be genetic and or metabolic abnormalities definitively associated with PIPO. Again, access might be an issue, but at least so how do these kids actually present? So like I said earlier, about 2/3 will present, well, actually 80% present by 1 year of age, and 2/3 actually present within the first month. The remainder of patients will sporadically present over the next 2 decades. Interestingly, PIPO can be diagnosed antenatally in about 20% of patients. Your scan is most sensitive after 16 weeks and becomes progressively more sensitive further on into the gestation. Megacystitis is the most frequently reported finding and may precede gastric symptoms by several months. So even if you have excluded gastric symptoms when your baby is born, it's important to follow them up if you've noted megacystitis on the antenatal scan. They can also have hydronephrosis, increased amniotic fluid, and interestingly, urological complications are more common on your antenatal scan than bowel involvement. Only 10% will have dilated loops of bowel on that scan. For neonates, they have persistent or recurrent features of obstruction, so bowel distension, bilious vomiting, and then they can also present with bladder symptoms and even small intestinal bacterial overgrowth. They can also have diarrhea as they're presenting symptoms, just to complicate things further. Older kids similarly present with features of bowel obstruction, and that tends to predominate in terms of what we find in terms of prevalence. Bladder involvement, like I gave the variable statistic earlier. So the ESPGHAN paper from 2018 gives a range of 33 to 92%, which is quite variable. The most recent paper I found came out of the Netherlands. They report about 47%, and a paper that had the biggest cohort of 105 children reported about 35%. So it probably is population dependent, which makes it really difficult, but I think it's important to look for. And unlike the adults, like I said earlier, children tend to have issues with growth failure, malrotation, and not a lot of abdominal pain. And diarrhea, like we saw in our case presentation of patient IM, is the presentation in only about 24% of patients, and that's because of the small intestinal bacterial overgrowth. All right, so investigations. So as with anything, we tailor our investigations to our patients and we use a stepwise approach. We generally do least invasive to most invasive. So in this slide, under each heading, the options that are there have been validated in the diagnostic pathway, and we'll go through each a little bit more. So for laboratory workup, We usually start with the more common things, and a lot of these are actually also to exclude other potential causes. So FBC, UNE, albumin, liver function tests, inflammatory markers, all help you exclude other causes, but can also help you differentiate between your secondary causes of PIPO. Neurotropic viruses like EBV and CMV, we look for more in immunodeficient patients or in patients where you have a suggestive history. And then you can do further testing depending on where your history and examination have guided you. In terms of genetics, most genetics, like I said, especially in the ones that we see in our population, are sporadic, and very few genetic forms of PIPO have been identified so far. And for metabolic screening, it's mostly helpful when you're looking for underlying mitochondrial disorders. But again, both of these form part of your diagnostic criteria. So the next two slides are also a little bit busy, and I've included most of the pros and cons here for reference. So if you'll just focus on the first column, these are the radiological investigations that have been recommended from the ESPGHAN list. And I've just tried to condense them into the advantages and limitations of each. So the first is abdominal X-ray, which is obviously quite helpful to rule out many mechanical causes of your common presenting symptoms. Again, not as helpful as in neonates, but in older kids, as many as 82% of PIPO patients had dilation of at least one region of the GI tract. So could be quite helpful. But what is important in abdominal X-ray is positioning, especially to see any air fluid levels. So in a child, you want them upright, and in a younger child who isn't able to stand independently, you want them in the lateral decupitous position. In well-resourced settings, Entero, CT, or MRI replace contrast studies because they're more accurate in excluding mechanical causes and identifying adhesions. And then the flip side to this is obviously cost and access and potentially anesthetic in a really small child who might require MRI. Manometry can be very helpful. And manometry can be done from the esophagus all the way down to the anus. But the area specifically in PIPO that it has shown to have to be the most discriminating is in the anterior duodenal manometry. And here it's helpful because almost all children with PIPO will have small intestinal involvement. And using manometry in this space, you can not only confirm your diagnosis, but you can actually kind of differentiate your underlying pathology. So we spoke about how the majority of patients will have underlying primary pathology, and you can differentiate between neuropathic or myopathic causes. So in manometry, your neuropathic causes will have a very disorganized, uncoordinated motor activity, and your myopathic causes have normal manometric patterns, but the amplitude is decreased. So we usually see an amplitude of less than 20. And like I said, it can be done all the way through your gastrointestinal tract, and you'll tailor it depending on what your presenting symptoms are. The last recommended radiological investigation would be gastric emptying scan. And we do this by nuclear medicine. And a normal gastric emptying scan can reliably exclude gastric involvement. And then you look at your emptying time. The limitation to this one is that we actually don't have normative values in children. So you may get the test, you may get the result, but how to interpret it in the context of your patient can pose a challenge. This is the other side of the coin. These are investigations that we do actually sometimes use, but the quality of the evidence is low. So the most common one that I've seen used, and unfortunately we have to use, especially in the public setting, would be contrast studies. So it used to be used even in well-resourced settings, but has since been replaced by CT or MRI. So what it is helpful for it can assist us with visualizing proximal dilatation in the area of the pathology, to the area of pathology, as well as your transit time. And like it says here, your presence of dilatation is evident in 59 to 82% of patients. So that's a fair amount, especially to use it as part of your diagnostic toolkit. What I didn't speak about in our non-invasive testing is endoscopy. And so the role of endoscopy in PIPO is basically as a rule-out test for mimics of PIPO. And it can also form part of your diagnostic toolkit, but it can't confirm your diagnosis of PIPO because the histological samples that you take from endoscopy aren't sufficient. So what you can do is laparoscopy, which also has its advantages and limitations. So in a patient where you're going to go for surgery anyway, for example, in the case of a patient where you still have an excluded mechanical obstruction, and this is the point that you're finally at, and you're going to do the surgery anyway, then the risk-benefit of taking a histological sample points more to doing it because you're going to be operating anyway. However, if you're doing a laparoscopy simply to get histology for diagnosis, then it becomes a little bit more gray. So while your diagnostic yield is quite high, it rarely impacts your management. So even though you get a diagnosis, you tend to manage these patients in the same way. And children with PIPO specifically are at more risk of post-op complications such as adhesions and paralytic ileus. Some may argue that it helps to prognosticate your patient. You can offer genetic counseling to your families, and you can also tailor your investigations for secondary etiologies more appropriately. But I think this is something that you do on a case-by-case and obviously as a multi-disciplinary team. Okay, so moving on to management. So management of our patients generally fall under non-pharmacological, pharmacological, and surgical. And there's quite a few options in each of these subcategories. And I'm just going to go through each one individually. So nutrition. Improving nutrition in a child with GI dysmotility can improve your mobility and mortality, but obviously it can be very challenging. So you can opt for a combination of different approaches, and these would include oral feeding, enteral nutrition, and parenteral nutrition, and that really depends on your patient and what they are able to tolerate. Children with PIPO often have malnutrition from malabsorption and food avoidance because of gastrointestinal symptoms. So this tends to be an issue that we have quite often. So some strategies that can improve enteral tolerance would be more frequent meals, meals that are low in fat and fiber, as well as avoiding lactose-containing beverages and carbonated drinks. You can give enteral nutrition either bolus or continuous, depending on your access and your patient. And ideally, gastric feeding should be considered first, as it's more physiological and easier in some cases. However, post-pyloric continuous feeds may be better tolerated in patients with PIPO. When considering parenteral nutrition, it's important to consider the indications and the complications and weigh up the risk-benefit. So you should think about introducing parenteral nutrition in patients with severe PIPO who are not tolerating their jejunal feeds or who have contraindications to enteral feeding. Again, there's a risk-benefit. So your long-term parenteral nutrition carries complications, and those can include central line infections, central venous thrombosis, and liver disease. Interestingly, 90% of patients with PIPO who die tend to have either infections or liver disease. So in addition to weighing up your risk-benefit, there's also the additional challenge of practically arranging home TPN. It's not always a safe or feasible option for many families. However, if done right, it can really change the outcome and also your lifespan of your patient. So it's important to think about it and advocate for it if it's available. Long term, a third of your patients will end up requiring partial or total parenteral nutrition. A third will require intragastric or enteral feeding, and only a third will be able to tolerate oral feeds. The objective of pharmacological therapy would be threefold. So one, you want to prevent bacterial overgrowth. Two, you want to improve gastric motility. And three, you want to manage pain. And you want to be thinking about all of these three domains. So for bacterial overgrowth, antibiotics that tend to be most commonly used in the pediatric setting would be augmentin, metronidazole, Bactrim, as well as aminoglycosides. And you also want to be careful to avoid prolonged use because of the risk of resistance. For motility, there are a number of drugs that can theoretically improve gastric motility. However, there's no one recommended drug in the pediatric group. And unfortunately, most of the studies are actually done in adults. So it is a bit of trial and error in the pediatric population to see what works specifically for your patients. In the adult group, the combination of prokinetics and antiemetics actually had really good effects, but trials in pediatric patients show a variable outcome, so perhaps something to consider in our older kids. And then other drugs that have shown to have good effects would be cholinergic agents like parastigmine, octreotide, and both of them have been shown to improve enteral feeding tolerance. So for pain management, it can be a challenge. Because a lot of the agents that we have for pain management can also have a negative effect on motility, but we do have options. So this is from a presentation actually by the Palliative Care Association, I think it was in Cape Town. And these are some agents that they recommend using in PIPO for mild to moderate pain. So obviously you have a ladder and you have to decide what's most appropriate. So these you can either use as primary agents or as adjuncts with stronger agents depending on your need. This is our options for severe pain. So you'll see morphine is on there, but specifically for short-term use. Fentanyl, PCAs or patches can be quite safe and effective if used correctly, and patches specifically avoid enteral absorption, so they can be quite helpful. Methadone is a good option for outpatients. It's absorbed in the stomach, and it can be actually a very good agent for bowel pathology. And ketamine in our inpatients are quite helpful for visceral pain. And then not to forget that you can also consider regional anesthetics like epidurals as well. So surgery would be the last step of management, and judicious use of surgical interventions is very important because, like I mentioned earlier, these patients have a propensity to develop post-op complications such as adhesions and ileus. So the two surgical options that we have to us that have been validated would be ostomies as well as intestinal transplantation. Small bowel resection are generally avoided because safety hasn't really been established, and it can lead to complications such as short gut syndrome and intestinal failure associated liver disease. So for ostomies, we have two options really. So you have gastrostomies or jejunostomies, and they provide a convenient route for feeding and medication, and you can also use them to decompress the gastrointestinal tract as well. These have been shown to reduce frequency of vomiting and number of hospitalizations in patients, and also have an impact on overall quality of life. And the second way you can use an ostomy is either as a defunctioning or decompressive enterostomy. So it's also shown to alleviate obstructive symptoms. It's useful though in about half of patients. So half of them don't find that it alleviates symptoms at all. So picking your patient is quite important. But what it can do theoretically is reduce stasis of gastric contents. It can reduce gaseous distension. It can decrease reliance on parenteral nutrition, and it can decrease the potential of bacterial overgrowth and potential translocation. So the risks is also something to think about with this group of patients. So you have a risk of stromal prolapse and you have a risk of intestinal necrosis. What's also not standardized is the anatomical level of insertion of these decompressive enterostomies. However, an ileostomy so far has been shown to have the highest rate of relief. And then lastly, intestinal transplant. So today, intestinal transplant remains the only definitive cure for children with PIPO. And overall, the outcomes and survival rates are improving up to 60% in 5 years. And this is because we have advances in our surgical techniques as well as immunosuppression. And we don't have this available in South Africa yet, but you would consider intestinal transplantation in patients with things like central venous catheter-related thromboses, recurrent line infections, or patients with very poor quality of life and who have a high risk of morbidity and mortality. So there are a few different types of intestinal transplant. You can either just do the small bowel and liver, or multivisceral. And this is from a center at King's College in London. And you'll see that the second most common reason for doing intestinal transplant are motility disorders in the pediatric group. But what I found also interesting is, despite the better outcomes, surgical techniques, immunosuppression, they're actually doing less transplants as the years progress. And the reason for this is they're improving the nutrition in this group of patients. So both enterally and better facilitation of TPN to avoid reaching this stage for with patients. And I thought that was interesting because that's a potentially achievable thing within our setting. Okay, so back to the case. So for patient IM, after considering all our options, this is the workup that we ended up ultimately doing for him. So we excluded more common things, especially IBD. We did a fecal calprotectin and an MRE, which was normal. He had 2 full thickness rectal biopsies. So the first was inadequate, but the second showed marked fibrosis in the muscularis propria. And that was in keeping with hollow visceral myopathy. He actually had the thyroid pattern, which I see I did not insert. But we ended up being able to diagnose him based on that. We excluded any bladder involvement in him. He did have that history of recurrent UTI, so it was something that we thought about. And in terms of management, we operate within a multidisciplinary team. So we referred him to dietitians, palliative care teams. We ended up doing a course of flagyl for his bacterial overgrowth, which ended up being quite effective. And he ultimately was able to be managed on rectal washouts and lactulose. So in him, we suspected that his underlying cause of his PIPO was the African degenerative leiomyopathy, largely because he did have that kind of thyroid pattern on his biopsy and because he had predominantly colonic involvement. So rectal washouts were really helpful for him. Lactulose is a bit controversial because we know that it can cause bowel dilatation and sometimes discomfort. But for him, he was able to manage quite well on it, and ultimately we ended up being able to stop it in him. And throughout, we were able to continue with enteral feeding, so he didn't need any escalation of his nutrition. Okay, so we're back full circle. And I hope that these concepts make a little bit more sense now that we have a little bit more context to them. And ultimately, I think in terms of what I want everyone to remember is that PIPO is not common, but perhaps it's more common than we think it is. So to always think about it in our patients, but to exclude common things first. Always think about the bladder and not to forget nutrition. Thank you so much, and special thanks to Tim and Nisha for all their help. These are my references, and that's me.
Thank you so much, Nouraine. Well presented and well researched. I'm going to open the floor to questions, and I'm not sure that I can see hands raised. So if you want to speak, maybe just unmute yourself and butt in. I think there's quite a lot of experience on the call with African degenerative leiomyopathy or hollow visceral myopathy, as we know it more commonly. And unfortunately, management of these children remains very, very difficult. I don't know if there are any surgeons on the call. No one's owning up to that. But I can tell you from speaking to surgeons, they themselves say, no, keep surgeons away from these patients because of the complications and because of the multivisceral involvement that eventually ensues and causes problems. Just checking the chat. Has anyone got questions or comments? Don't see any yet. I'm reflecting on these cases. I think we find a new one once a year or every second year, and pretty much all of them have come in with severe malnutrition. And I think that's the one thing that we can sometimes do something about, at least in the initial stages. And enteral nutrition and low residue feeds tend to help with the nutritional status, but eventually we end up, unfortunately, with palliation and end of life care. So I think you've stunned everyone. No one is raising a hand or unmuting or chatting, except to say you've done a very nice presentation. So I think unless someone still wants to butt in, I'm going to say thank you very much to Nouraine. I think it was an excellent talk. And then, of course, thank you to the iEcho New Mexico team, the iEcho India team, who provide the technical support. These webinars are always going to be available as recordings on the Gastro Foundation website. Thank you to the Gastro Foundation and the sponsors. And for those of you who want to know more pancreatology, that will be the topic for next week. Thanks, everyone.